So I've done a video on acute heart failure management and exacerbation, and I've done a video on base heart failure management, but that was a while ago, and I didn't actually add the newer drugs that we now use today, some of which are actually even present in our country as I speak. So let's talk a little bit about heart failure management. This is a step-by-step guide. Grab your piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is my YouTube channel where we look at medical topics in depth. Today we're going to be looking at heart failure management. This is a step-by-step guide. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon so you can never be missing such amazing content every time I post. Drop a like, drop a comment to show some support. If you haven't watched the previous video on heart failure exacerbation, I'll leave it tagged at the end of this particular video. I'll also leave it tagged as the pinned comment on this video. Please do watch that video. And we also did a video prior on heart failure. If you just start by watching this particular video, you may be a bit confused because there are some terms that I actually did explain in that past video that you actually need to watch to have a good idea of this particular video. Largely, the changes that are going to be there in comparison to that video in this video is just pretty much the management, because here we're just going to be focusing on the management. So generally, remember that the management of heart failure is going to be divided into non-pharmacological management and pharmacological management, and in some cases surgical management. But largely this is going to be reserved for treatment of underlying causes. For example, someone with a myocardial infarction and they have heart failure, then you could put that candidate or push that patient as a candidate for the percutaneous coronary intervention or possibly even a coronary bypass graft. So generally, our goals are going to be divided into short-term and long-term. In the short term, you want to relieve the symptoms. You want to improve the hemodynamics. You want to avoid any acute complications that could potentially be detrimental to your patients. Things like electrolyte imbalances, especially with potassium. You want to avoid any hypokalemia. You want to avoid renal dysfunction, especially in patients that are dehydrated and are receiving drugs like ACE inhibitors, drugs like angiotensin receptor blockers, drugs like angiotensin receptor antagonist with neprilysin. You want to avoid those drugs, especially if they have renal dysfunction. Oh, there are some drugs that you should modify when there's renal dysfunction, like digoxin, but we'll talk about that during the course of this lecture. Even in those patients that have symptomatic hypotension, you generally want to avoid that in the acute phase. Then you also want to control the neurohumoral activation, and in the long run you want to correct the hypertension. You want to prevent myocardial infarction. You want to prevent the progresses of atherosclerosis. You want to prevent complications from happening. Generally, you want to improve the cardiac function. You want to reduce the hospitalization, improve the quality of life, and improve the survival of this person. Remember, there are some drugs that are going to be increasing the survival outcomes of this patient's drugs like ACE inhibitors, drugs like sodium glucose cotransporter 2 inhibitors are going to be improving the outcome and should be added to the regimen of these patients that are heart failure patients. While other drugs may not necessarily have any effect on the mortality, but there are some that can actually even potentially increase mortality rates. For example, calcium channel blockers in the acute phase, some beta blockers in the acute phase, even some drugs like positive inotropes like the dobutamines, the dopamines, the epinephrines could potentially actually increase the mortality rates in your patients with heart failure. Generally, the principles of management, we want to identify and treat the underlying factors as well as the underlying cause. You want to control the congestive state. So this is going to be done with diuretics. You're going to improve the myocardial function. This could be done with vasodilators, nitrates, which are going to relieve in the stress on the heart. They can be done even with beta blockers. It can be done even with drugs like the cardiac glycosides like digoxin. You also generally want to prevent this person from deteriorating, slow the progression of the heart failure. You can't stop it, but generally you can slow it down. So those drugs that improve survival generally are going to be slowing down the progression. Then there is a role for surgical intervention, like I said, but largely to be in those patients that, for example, they need some revascularization and you may need a percutaneous coronary intervention or a bypass graft. It could be those patients that are candidates for cardiac transplant. They could be getting a device therapy. They could have an implantable cardioverter defibrillator. They could have cardiac resynchronization therapy. They could have mechanical circulation circulatory support. What are some of the indications of admission? Generally, if someone presents with an acute exacerbation, anything that can cause an acute exacerbation, you want to admit that patient, especially maybe in the background of patients that have some other serious conditions like acute coronary syndromes, atrial fibrillation with a very rapid ventricular rate, those patients that have a hemodynamically significant arrhythmia, those patients with severe hypertension, those patients with aortic valve regurgitation. If they present with features of systemic or pulmonary edema that is significant, admit them. If they have worsening renal function, altered mental state, dyspnea at rest, significant hypoxemia, electrolyte imbalances, we're very much worried about potassium. If they are presenting as a new onset of heart failure, or they have severe symptoms, or they have heart failure that is not responding to outpatient treatment or their regular medication, you want to admit that patient. Generally, those patients that have mild exacerbations may not even actually come into your hospital, so they may actually even be treated at home. And remember that in terms of treatment of heart failure, the different drugs and the different classes of drugs that we give patients tend to respond to them differently. So generally, the response to the drugs, even the side effects that some patients may experience tends to vary. So which is why you must always individualize the treatment. There is, of course, some general things and some drugs that we advocate for most, if not all, the patients, but there are some drugs that you are going to be adding in certain particular scenarios. We'll talk about that very shortly. And remember that as the world is advancing, there is what is known as evidence-based medicine, and most of the medicine that we're practicing now is evidence-based. And most of the trials that actually have been done are actually done specifically on a group of patients that have heart failure with reduced ejection fraction. Remember that heart failure is going to be divided based on the functional classification based on the ejection fraction. Remember, ejection fraction is the ratio of the end diastolic volume, or rather, the stroke volume divided by the end diastolic volume expressed as a percentage, with the normal ejection fraction greater than 50%. So if they have heart failure and they have an ejection fraction greater than 50%, we call that as heart failure with preserved ejection fraction, what is referred to as HFpEF. Then if they have heart failure and they have reduced ejection fraction less than 40%, we say that that's heart failure with reduced ejection fraction. Then between 41 to 49% is like a gray area. So this gray area is what is known as heart failure with mid-range or mildly reduced ejection fraction. So most of the evidence, most of the trials are often done on patients with chronic heart failure with reduced ejection fraction, but the fewer trials actually have been done on those with preserved ejection fraction, those with mid-range ejection fractions, those with acute heart failure syndromes, and even those with right ventricular failure. So generally, we'll begin with our non-pharmacological management. The most important thing is to always keep the family and the caregivers in the loop. Remember that these are the people that are going to be responsible for reminding your patient at home to take the medication. These are the people that are going to be responsible for cooking for this patient at home. They're going to be responsible for how much salt this patient is going to be taking in. Research has shown that the more the caregivers actually involved and the family are involved in the care of this patient, the better the treatment outcomes and the less hospitalizations you're going to be facing with that particular patient. We want to counsel them on several things. The first important thing is salt restriction, dietary salt restriction. Remember, salt, sodium chloride. Wherever sodium is in high amounts, water tends to follow. So generally, we want to restrict the salt. We don't want to get rid of all the salt, because remember that they still need a bit of that sodium to be excreted into the kidneys so that that excess water can also be lost. But generally, we want to limit their salt intake to less than 2 grams per day, especially for those that are severely ill. And we should eliminate salt in cooking. Don't add a lot of salt. And I often like to tell my patients, don't add salt over the table. Not a good practice. But they should consume foods that are low in sodium. They should monitor their weight and they should weigh themselves daily, restrict their fluid. And if they gain weight rapidly, for example, they gain 2 kg in 3 days, that's a red flag. Then they should actually come to the hospital. In some cases, you can actually teach them how to modulate their diuretic doses. But in our case here, this may not be feasible because some patients come from a low educational background and they come from a low socioeconomic status. They may not understand how to do this. Then generally, you do advise them for weight loss, especially if they're obese, but they should avoid excessive exercise, and it should be exercise within their limits. So something like a walking. This is important because it's going to help prevent the muscles, the skeletal muscles, from being deconditioned because they are bedridden all the time. But generally, activity itself does not going to improve the survival rates. It will not decrease the hospitalization. And remember, when they do have exacerbations, they should rest. Formal exercise cardiac rehabilitation is actually quite useful in those patients with chronic heart failure with reduced ejection fraction, and can also even help those patients with preserved ejection fraction. They should stop smoking and drinking alcohol for obvious reasons. And remember, one of the reasons of exacerbation is infections, especially with viral respiratory infections. So you want to vaccinate them against influenza. You want to vaccinate them against COVID. You avoid any exacerbating factors like NSAIDs that can cause fluid retention, verapamil, which may have a negative inotropic effect on the heart. We give them oxygen. Remember that if they have a saturation less than 95%, you want to give them oxygen. And for those that are class 1 or class 2 New York Heart Association, they tend to actually tolerate exercise. We treat any comorbidities such as ischemic heart disease or coronary artery diseases. We treat any arrhythmias, we correct any anemia. Remember, when you're transfusing them, it's better to give them packed cells as opposed to whole blood. And we treat any dyslipidemias. Involve the family, the caregiver, and the patients. Counsel them on the importance of drug adherence, the warning signs on them exacerbating, and how to link whatever the cause with the effect. So, for example, if they increase their salt in their diet, maybe that's what's causing them to gain weight. That's what's causing them to have symptoms. In terms of the nursing care, you want to maintain the patient in position, elevate the extremities, except when the patient is in acute distress. I had a consultant that used to say, avoid actually elevation of the limbs in heart failure patients because you're going to overwork the heart. You're going to strain the heart, in essence, which is already failing. You want to frequently monitor the vital signs. You want to change the position frequently to prevent your bed sores. You want to use an input-output chart, weigh the patient each and every single day, restrict any fluids as is recorded in the track chart. You want to teach your patients and the family to provide this emotional support, lifestyle changes. And you explain the side effects. It means that if you're not knowledgeable about the side effects and how the drugs work, you're not going to do a good job with your heart failure patients. For example, your diuretics that are going to be causing electrolyte imbalances like hypokalemia in terms of the potassium wasting diuretics, or even hyperkalemia in terms of the potassium sparing diuretics. You also want to offer you also want to offer, or rather perform, aseptic procedures whenever indicated. So here are the group of drugs that are often going to be used in the management of heart failure. I've divided them largely into two groups. The first group is simply going to be the drugs that are going to be offering this symptomatic relief. They're not going to be necessarily increasing the long-term survival, or rather, they're not going to be improving the mortality rates. Then the second group of drugs are the ones that are going to be used for long-term management. These ones are going to improve the survival rates of the patient. So you have those that are offering symptomatic relief, like diuretics. The loop diuretics are quite common. Furosemide, bumetanide, and torsemide. These ones can actually be used as a single drug, or they can be combined with thiazide diuretics, especially in those patients that are quite resistant, what we call loop diuretic resistant patients. We can actually combine them with the thiazides like hydrochlorothiazide, metolazone, or clothalidone to actually help the patients. In some cases, we may use aldosterone antagonists like spironolactone and eplerenone. We do now have eplerenone in the country. And in terms of aldosterone antagonists, remember that these ones are potassium-sparing drugs. They're mineralocorticoid antagonists. So they also do actually have some effect on the survival rates because they block aldosterone, which has been shown to be implicated in the cardiac remodeling that we see in heart failure patients. So they're the only diuretics that are actually going to be improving survival rates. Then you may use nitrates and vasodilators, which are going to be reducing the workload on the heart. They reduce the afterload. So generally, drugs like isosorbate dinitrate, you can use drugs like hydralazine. Remember, you want to avoid vasodilators like calcium channel blockers because generally those have side effects of causing pulmonary edema. They can cause angioedema, and they should be avoided generally even in the acute phase, unless if they're being used to treat something like a hypertension already in the past. Then you also want to put these patients on these drugs that are going to improve their survival. A good group of drugs are ACE inhibitors. They have been used for quite some time. Drugs like enalapril, lisinopril, ramipril, angiotensin II receptor blockers like losartan, candesartan, valsartan, and the aldosterone antagonist, the mineralocorticoid antagonist, which I've already talked about, spironolactone and eplerenone. There is a newer group of drugs. Those are the ACE angiotensin receptor inhibitors combined with a drug that's known as neprilysin inhibitors. That's sacubitril as well as valsartan. This is a very good drug. It's actually most of our patients, I think in some time to come, are actually going to be switched from actually receiving ACE inhibitors to be put on sacubitril as well as valsartan. But then we cannot really combine sacubitril with any other angiotensin II receptor blocker because it has been shown to cause significant hyperkalemia. So generally, you have to watch out for the potassium levels whenever your patient is on this drug. And if you're switching from an ACE inhibitor to this drug, the angiotensin receptor with neprilysin inhibitor, you generally have to wait a few hours, about 36 hours before you actually start the drug, so that you can wait for the ACE inhibitor to clear out because of the effect of hyperkalemia that you do not want in your patients. Beta blockers are also going to be avoided in the acute phase, but in the long run can actually be used, especially for those patients that have arrhythmias, especially your atrial fibrillations. Carvedilol, bisoprolol, metoprolol are examples. Then there is a group of drug that is used actually even in the management of diabetes. That's the type 2 diabetes, the sodium glucose co-transporter 2 inhibitors that leads to excretion of glucose in the urine. So drugs like dapagliflozin and empagliflozin are the two drugs that also have been shown to have some sort of effect, even in the patients that have heart failure. I'll talk about them very shortly at the end of this lecture. You also have the sinus node inhibitors like iverabardine, which can be used as well, which block a special type of sodium channel that is found at the SA node. So we can also use some drugs like vasopressin receptor antagonists, though they're not going to be commonly used. But in some patients that do have refractory hyponatremia, in patients with heart failure, we can use these drugs. So begin with the very first group of drugs, which are going to be the diuretics. Remember that these ones are going to be used in all patients that have heart failure, regardless of what your ejection fraction is. As long as they have some element of congestion, you're going to use these drugs to reduce congestion to prevent edema. So generally, they are going to be three main groups: the loop diuretics, thiazide, and aldosterone antagonists. Generally, the loop diuretics are the ones that are commonly used. If a patient is resistant or refractory to the loop diuretics, we can consider adding a thiazide diuretic. So we'll start with the loop diuretics. These ones are going to be generally used to control the volume overload. So the dose, actually, if you are combining them with aldosterone antagonists, you should reduce the dose of the loop diuretic. So wherever necessary, you can actually combine them with an aldosterone antagonist so that you can use lower doses. But generally, our starting dose with furosemide, 20 to 40 milligrams orally, once a day or twice a day. If it's IV, 20 milligrams, and you can titrate upwards based on the response up until you reach 120 milligrams twice a day. So a maximum dose of 400 milligrams orally per day or 80 milligrams IV per day. Bumetanide, 0.5 to 1 milligram orally once a day. You can reach up to 2 milligrams orally twice a day, meaning it has a better bioavailability compared to furosemide. Tosamide also with a better bioavailability, 10 to 20 milligrams OD once a day, and you can titrate up to 50 milligrams twice a day. So remember that your titration, like I said, based on the response, based on the renal function, and bumetanide, tosamide, better bioavailability than furosemide. When you're switching in between these drugs, make sure that you give the equivalent dose of the other drug. For example, if you're giving 40 milligrams furosemide and you want to switch to bumetanide, you would give 1 milligram. If you want to switch to tosamide, you'd give 20 milligrams. And like I said, in cases where the loop diuretic are not really working, you may actually consider adding metolazone 2.5 to 10 milligrams orally. In some cases, we may give an infusion of Lasix 5 to 10 milligrams IV, or other diuretics in some cases, especially when they have severe edema. Before you actually do this, make sure you push in a bolus of the diuretic, and then as you're increasing the infusion, make sure, again, you push in a bolus each time you increase the infusion rate. Then in terms of thiazide diuretics, remember these ones, like I said, are not normally used on their own, unless if it's a patient that was already on them and they were being treated for hypertension. So generally, one common drug that we use is hydrochlorothiazide, our initial dose of 25 milligrams per day, but a maximum dose can actually reach about 100 milligrams orally per day. In terms of the aldosterone antagonists, these ones, like I said, of the 3 diuretic groups that we use in the management of heart failure, these are the only group that actually have been shown to improve the survival rates. They do reduce mortality. Why is this so? Because remember that they are blocking the effects of aldosterone. Aldosterone causes the cardiac remodeling. So they are blocking that cardiac remodeling, and they do actually improve the mortality rates, and they prevent sudden death, especially in patients with a left ventricular ejection fraction that is less than 30%, in patients with chronic heart failure, in patients with acute heart failure that is complicating an acute myocardial infarction. Remember that these drugs here, one of the bad things that they do is that they're going to retain potassium. So there's a high risk of developing hyperkalemia, especially if they're combined with the ACE inhibitors, and especially if they're combined with the angiotensin receptor blockers. There's a high risk of actually them developing hyperkalemia. More so if this patient has some sort of dehydration or they have some sort of renal dysfunction, they will cause a hyperkalemia. So you want to keep monitoring the effects of the drugs. You want to keep monitoring the electrolytes. They may also even be beneficial in those patients with liver disease, especially those that have chronic right ventricular failure. They have this hepatic congestion and they can't clear out this aldosterone. So generally, and they can't even metabolize aldosterone. So generally, they would benefit for that, which is why even in patients that have chronic liver disease, we often put them on higher doses than the ones that we use in cardiac range. We put them on higher doses of spironolactone. They do, so in order for us to reduce the risk of hypokalemia, generally, if the potassium concentration is above 5.5, we don't give them. If it's less than 5, we can give. If the serum concentration of creatinine is less than 221 micromoles per liter, we can give. If the GFR is greater than 30, we can. And remember that 25 milligrams of spironolactone is going to be roughly equal to about 50 milligrams of eplerenone. So we start off with our spironolactone at 25 to 50 milligrams once a day, then eplerenone 25 to 100 milligrams once a day. And one advantage of eplerenone compared to spironolactone is eplerenone will not cause that significant gynecomastia in males compared to spironolactone. And generally, if they're taking any potassium supplements, stop those because they will potentially potentiate the effects of hyperkalemia. And also, remember the use of aldosterone, and if the patient is taking other drugs like digoxin, may affect how digoxin is actually working. So you should check your serum potassium and creatinine every 1 to 2 weeks for the first 4 weeks. That's for the first 1 month or 1 month, 2 weeks. Then we lower the dose if the potassium is between 5 to 5.5, and we stop it, like I said, if it's above 5.5. If the creatinine is above 220, or if there are ECG findings of hyperkalemia, I've already done a video on hyperkalemia, you make sure that you stop the spironolactone or the eplerenone. So in the effects of hyperkalemia are actually seen much more with spironolactone compared to eplerenone actually. So in patients with heart failure with reduced ejection fraction, we can consider giving them an aldosterone antagonist with either an ACE inhibitor or an ARB. It's actually preferred over a combination of an ACE inhibitor plus an ARB in a patient. Then remember that those patients with heart failure with preserved ejection fraction, the spironolactone will reduce their hospitalization and will likely even potentially reduce their cardiovascular mortality risk. So it means that you should add spironolactone wherever necessary to your patients with heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, especially those that have volume overload. Then these diuretics do come with some side effects. The loop diuretics, especially when they're combined with metolazone, may cause significant hypovolemia with significant symptomatic hypotension. It may lead to hyponatremia, it may lead to hypomagnesemia, and even severe hypokalemia. There may be some renal impairment, so like I said, keep monitoring your UNEs, add potassium-sparing diuretics, especially if your potassium is less than 3.2, because this may predispose them to arrhythmias. And then if they're taking digoxin therapy, remember it decrease in potassium actually will increase the toxicity of digoxin. So you may want to be wary of that. And if you're using larger doses than required of the diuretics, they can also lower the cardiac output. They may impair renal function. They may cause hypokalemia. They may actually even potentially increase your mortality rates. So you monitor your electrolytes, you monitor your renal function initially each and every day, especially if you're using IV formulations, and then you can monitor them as you adjust the doses. So remember that the dose of the diuretic acutely can be gradually reduced, and you want to put it at a target where you have the lowest dose that's going to keep your patient stable, the weight of the patient stable, and the symptoms being controlled. So when the heart failure actually improves with time, to some extent, then we can stop the diuretics if you are on these other drugs that can actually help maintain the heart function, and they'll help relieve the symptoms. The next group of drugs are the vasodilators. So generally, these ones are going to be used in patients that have severe heart failure. Remember how they're going to be working. They're going to be causing vasodilatation. And remember, once the arterioles and the arteries dilate, this is going to reduce the peripheral resistance. So this reduces the resistive force to the flow of blood. It means that the heart now doesn't have to necessarily generate a greater force to overcome the resistance. So the workload on the myocardium is reduced. So potentially it will improve the cardiac performance. It will improve the contractility. So generally this is going to improve the hemodynamics. It's going to reduce the valvular regurgitation. It increases the exercise capacity, minus causing any significant renal impairment. Though these drugs are not commonly used in heart failure patients because they have largely been replaced with ACE inhibitors and ARBs, which have been tolerated well in heart failure patients. And there are now even newer drugs like the angiotensin receptor blockers combined with neprilysin. That's the sacubitril with valsartan. So remember that these ones, the hydralazine in combination with isosorbide dinitrate, can be used especially in those patients that cannot take the ACE inhibitors or they cannot take the ARBs. For example, they have significant renal dysfunction. Although there is little data that has been shown, in order for us to make a conclusive practice based on the evidence, though in African patients or those that are of African ancestry, we can actually combine these two drugs, and they have been shown to decrease the mortality and hospitalization and improve the quality of life in these patients. When you are using these drugs with an ACE inhibitor and ARB as part of the therapy, hydralazine can be started at 25 milligrams 4 times a day, and then we can increase every 3 to 5 days to a target of 300 milligrams per day. But by the time you actually even cross 200 milligrams per day in some patients, you see that they become quite significantly hypotensive and they can't actually even tolerate. Then the isosorbide can be started at 20 milligrams orally 3 times a day. Then you have these 12-hour interval free where they're not having any drug, and then you increase to a target of 40 to 50 milligrams 3 times a day. So remember, when these drugs are added to an ACE inhibitor or ARB therapy, the hydralazine and nitrate therapy may be beneficial, especially for those that have heart failure with reduced ejection fraction. So you may start at a lower dose of 37.5 milligrams hydralazine and 20 milligrams 3 times a day of isosorbide dinitrate. And you can reach a maximum dose of 75 milligrams of hydralazine and a maximum dose of 40 milligrams 3 times a day of isosorbide dinitrate. But remember that whether you're going to decide whether you're going to add this hydralazine and nitrate to your ACE inhibitors or your ARBs would depend on the response. It would depend on the tolerance of the drugs and the symptoms that the patient generally has. But this regimen has been largely replaced by the ACE inhibitors and the ARBs. So remember, like I said, calcium channel blockers, we want to avoid them. They're not going to be used to treat any left ventricular systolic dysfunction. The short-acting dihydropyridines like the nifedipine and the non-dihydropyridines like diltiazem and verapamil, these ones are quite dangerous, so we want to avoid them. Amlodipine, felodipine are better tolerated, especially those patients that do have heart failure and angina, for example, and heart failure and hypertension. But we want to avoid these drugs because they do cause peripheral edema. Amlodipine sometimes can cause pulmonary edema. There is a risk of angioedema. Generally, with felodipine, we want to avoid taking it with grape juice. Remember that grape juice is generally going to be inhibiting the enzyme, the cytochrome P450 enzyme, which means that less of the felodipine is actually being broken down, so it can actually increase the plasma levels of felodipine and cause dangerous side effects. In those patients that do have heart failure with preserved ejection fraction, the dihydropyridine calcium channel blockers like amlodipine, for example, can be used, but only if they have hypertension or ischemia. While as the non-dihydropyridines like diltiazem and verapamil, these ones are often used for rate control, especially in atrial fibrillation, the ventricular rate, controlling the ventricular rate. Then in terms of verapamil, it can also be used in hypertrophic cardiomyopathies, but generally in the acute phase, we tend to avoid these. Then in terms of nitrates alone, these ones can be used to relieve heart failure symptoms even in the acute phase. We talked about this when we looked at acute decompensation of heart failure. We can use this in patients with heart failure with reduced ejection fraction, and it can be given as a sublingual nitroglycerin spray for those that have acute dyspnea, or a transdermal patch that they can put at night or when they have exertional dyspnea. Remember that in heart failure with reduced ejection fraction, your nitrates are quite safe, they're effective, they're quite well tolerated, especially if your patient has heart failure and angina. One of the side effects is that they do cause a headache because they cause this vasodilatation. They also do cause hypotension. The isosorbate mononitrate has been tested in patients with preserved ejection fraction. It has been associated with increased side effects like headaches and even reduced physical activity. So routine use of these long-acting nitrates generally is avoided in patients with heart failure with preserved ejection fraction. Then we move now to a large group, which I will spend a bit of some time talking about. Though we don't routinely use this drug quite often in the hospital because it has been replaced by better drugs. So these are cardiac glycosides and inotropes. Remember that potentially some of these can increase your mortality risk, and they're going to be positive inotropic drugs, and these are going to be grouped as adrenergic or acting drugs like norepinephrine, epinephrine, dobutamine, dopamine, or even non-adrenergic drugs like your milrinone and the other different groups of the drugs. Generally, use of inotropes is discouraged in heart failure patients. Things like dobutamine discouraged because they do increase the mortality and they're not so recommended. But in the extremes, especially those that are having severe heart failure with reduced ejection fraction for palliative purposes, we can use these dobutamines and milrinone drugs. So in terms of digoxin, remember that it's going to be working to block the sodium-potassium ATPase pump, and generally this is going to result in certain effects. Number one, it has an effect on the contractility of the heart, so it will have a weak positive inotropic effect. Inotropic effect. So it will increase the contractility to some extent. So it tends to improve the cardiac output. The second thing is that it's going to reduce the sympathetic activity. So this will have a effect on the rate of the heart. So generally to block the conduction of the AV node. So it will slow the ventricular rate, especially in patients with atrial fibrillation. It can also prolong the PR interval in a patient that has a sinus rhythm. The other thing that it's going to do is that it's going to reduce the vasoconstriction, and it's going to improve the renal blood flow. It's largely excreted in the kidney, so it means that if someone does have some renal dysfunction, you have to actually look at the dose and modify the dose of the digoxin. It has an elimination half-life of about 36 to 40 hours in a patient with normal renal function. And like I said, it has no proven survival benefits. And when used with diuretics and ACE inhibitors, it may actually control the symptoms and it may reduce the likelihood of hospitalization, but doesn't have any significant effect on survival benefit. So the bioavailability of the available evidence-based treatment, especially of use of digoxin in heart failure with reduced ejection fraction, is quite limited. So generally the use of digoxin has been reduced because there are other medications that can actually be used to improve survival outcomes of your patients. So we do not use it in patients with preserved ejection fraction unless if you're using it to control the heart rate. For example, if they have a concomitant atrial fibrillation, or you want to augment the right ventricular function when they have right ventricular failure. It's actually effective if your patient has a large left ventricular end diastolic volume and they haven't a third heart sound, then you can consider digoxin. For those that are started on digoxin, maybe it can help the symptoms in those with sinus rhythm. You should consider it for those patients that have left ventricular systolic dysfunction, those that have clinical features of heart failure while they're receiving the other drugs like ACE inhibitors, beta blockers, or if they have a concomitant atrial fibrillation and you want to control the rate, digoxin is where to go. So remember, we do not want to acutely stop this because it may increase the risk of them hospitalizing. It may increase the rate, the heart rate. It may also worsen the symptoms. In terms of the dose, if there are patients that are coming in with normal renal function, then we can give them 0.125 to 0.25 milligrams orally once a day, depending on their age, their sex, their body size, and until they are fully digitized in about 1 week. So that's about 5 half-lives. So remember that in some cases, we may do what is known as rapid digitalization. We don't do this in our setting currently because there's no need for it. There's no role generally, especially when you're treating atrial fibrillation. There's little reason why you should actually rapidly digitalize or load digoxin into your patients with heart failure. But if you do for some reason, you can actually start off by giving them 0.5 milligrams IV over 15 minutes. Then you give them 0.25 milligrams IV at 8 hours and at 16 hours. Or you can give them 0.5 milligrams orally, followed by 0.25 orally at 8, 16, and 24 hours. And remember that these prescription patterns are going to be varying widely based on the different countries, even in different hospitals and different physicians. But generally, the doses are lower than what we used to use in the past. And the trough, which is 8 to about 6 hours after the dose, is roughly about 0.8 to 1.2 nanograms per mil, which is preferred. So generally, we don't need to rapidly digitize our patients. So just giving them a 0.125 once a day if they have normal renal function, or 0.125 on Monday, Wednesday, and Friday. Those that have abnormal renal function could be sufficient enough in your patients with heart failure. Remember that it's going to be renally excreted, so you need to adjust the dose based on the renal function. You maintain your potassium between 4 to 5 millimoles because hyperkalemia and hypokalemia will potentially affect how digoxin is working. It's relatively contraindicated in patients with cardiac outflow obstruction like mitral stenosis, in the absence of an atrial fibrillation, and in drugs in condition like copamolone, this drug is contraindicated. Remember, it has a narrow therapeutic index, so it may have a wide range of side effects, GI effects like anorexia, vomiting, weight loss, neuralgia, delirium, yellowing of the vision. You see these halos around objects, gynecomastia, arrhythmias of different types, which I'll talk about in the next slide. So when the electrolyte imbalance is suspected, you stop the digoxin, you observe the patient for some days before you actually start at a much lower dose. You should also contemplate giving them potassium chloride, which will actively compete for the binding site. Because if they have hypokalemia, it does potentiate the effects of digoxin. So remember that you're going to need a lower oral dose, especially for older patients, for those that have a lean body mass, for those that are taking amiodarone. And the most important arrhythmias that you should fear is things like ventricular fibrillation, ventricular tachycardia, complete atrioventricular blockade. You may have a bidirectional ventricular tachycardia and non-paroxysmal junctional tachycardia in the presence of an atrial fibrillation, and hyperkalemia. These are some of the side effects of the digitalis. Then you may have nausea, vomiting, anorexia, which I've talked about, diarrhea, confusion, amblyopia, and rarely xerophthalmia may sometimes be seen. And remember, hypokalemia or hypomagnesemia, if you're using diuretics, can actually cause toxicity, potentially exacerbate the toxicity of digoxin. So you monitor your electrolytes, and you should treat them and prevent them if possible. Give them a potassium-sparing diuretic, which may help. When you're handling a digoxin toxicity, you want to stop the digoxin, you want to check your electrolytes, and then these electrolyte abnormalities should be corrected. Give IV formulation, give potassium chloride, don't give slow K. Then for the patients with severe toxicity, you admit them to an ICU. Preferably, you may give them the digoxin immune binding antibodies. Then if they have arrhythmias that are quite severe, or they have significant ingestion of the digoxin that's accompanied by a potassium concentration greater than 5. And remember that the digoxin antibodies can actually be useful for glycoside toxicity due to ingestion of the plant itself. So remember that the dose is based on the steady state serum of digoxin levels, or the total amount that is ingested. Then the ventricular arrhythmias are treated with lidocaine and phenytoin, your AV blockage with a slow ventricular rate, may actually require a temporal transvenous pacemaker. Isoproterenol is actually contraindicated because it will increase the risk of ventricular arrhythmias. We move now to the next group of drugs, which are the ACE inhibitors. So remember that these ones are going to be used for those patients that have heart failure with reduced ejection fraction. Then they can be given the oral ACE inhibitors, unless if there's some contraindications. For example, they have a plasma creatinine greater than 250, they have bilateral renal artery stenosis, they have renal artery stenosis with one kidney, they have previous angioedema or some hypersensitivity, severe hypersensitivity reaction to ACE inhibitors. But otherwise, if they do have no contraindications, we can give them the ACE inhibitors. Remember, these ones are working by blocking the conversion of angiotensin 1 to angiotensin 2. They also block the breakdown of bradykinins into inactive compounds. So remember that these are going to then be mediators that can affect the sympathetic nervous system, they can affect the endothelial function, they can affect the vascular tone, they can affect the myocardial performance. So generally, they're going to be causing dilatation of both the arteries and the veins. Remember, when the arteries are dilating, the total peripheral resistance is decreasing. When the veins are dilating, your preload is decreasing. And according to a Frank-Starling phenomenon, the heart also, the contractility, it won't contract as much. Generally, there is going to actually have a sustained decrease in the left ventricular filling pressures at rest and during exercise. There's a decrease in vascular resistance, and it will have favorable effect on the remodeling of the ventricles because ultimately aldosterone will not be produced. So they do have been seen to show improvement in survival rates and to reduce hospitalizations due to heart failure. So patients that are at risk of MI, stroke, especially in atherosclerosis, those with vascular disorders, put them on ACE inhibitors. It reduces the risk. For patients with diabetes, it would delay the onset of the nephropathy and can be used even in patients with diastolic dysfunction. We want to start really low. So about a quarter to about a half of the target dose is what we're going to be starting. And this is going to be based on the BP of the patient, based on the renal function. If they're hypotensive, you want to avoid the ACE inhibitors. If the BP is low or borderline low or close to the lower side, then you want to start off with a smaller dose. If the BP is high, you want to start off with a higher dose. So generally, the dose is going to be adjusted upwards over 8 weeks as tolerated. And enalapril is going to be given at a 10 to 20 milligrams orally twice a day, lisinopril 20 to 30 milligrams once a day, and ramipril 5 milligrams twice a day. But there are different other drugs. These are just 3 common examples that I've given you. So remember that if the hypotensive effect, or it's actually much more marked in patients with hyponatremia and those that are volume depleted. So generally, we can reduce the dose of the diuretics if they're on the diuretics, such that we can use the ACE inhibitors, or you can give them a longer acting ACE inhibitor like perindopril, or you can give it at bedtime if you're having effects of them being hypotensive. Generally, the ACE inhibitors will cause some mild to moderate elevation in the serum creatinine because of the effects of the vasodilatation that is happening in the efferent arteriole. So generally, you're not going to stop the drug based on this. So your initial 20 to 30% GFR, or rather, creatinine increase is not enough to stop the drug. So generally, just keep monitoring it, slowly increase the dose, and also reduce the dose of the diuretic. Avoid any other drugs that may potentially worsen renal function, like the NSAIDs, avoid those. And generally, NSAIDs in heart failure patients are generally avoided. So because the effects of aldosterone are going to be reduced, you may have the potassium retention with these ACE inhibitors. So potentially, if they are combined with potassium-sparing diuretics, or they are given with potassium supplements, you may result in a hyperkalemia. And because of those bradykinins that are not broken down, they may accumulate and cause this dry cough in about 5 to 15% of the patients. They may have a rash or dysgeusia that may occur, and angioedema sometimes is a complication which is rather life-threatening. To reduce on these complications, you may switch them to an alternative which is known as an ARB, but remember that angiotensin receptor blockers, ARBs, are both going to be contraindicated in pregnant women. So your serum electrolytes and your renal function, you monitor those at the start. You're going to do them at 1 month, and then each time you're going to increase the dose or change it in the clinical condition of the patient. You monitor the renal function. So if they have dehydration, or if they have some poor renal function, maybe because they have a dehydrating illness, or they develop something, the ACE inhibitor dose may need to be reduced, or the drug may be temporarily stopped. Then in patients with heart failure with preserved ejection fraction, there is a randomized controlled trial of the ACE inhibitor perindopril that actually showed that it does increase the exercise capacity. It does not improve survival, although there was actually a high rate of crossover from placebo to the ACE inhibitors in this group, in this particular trial. So given that there is a high prevalence of hypertension, especially in patients with heart failure with preserved ejection fraction, it's actually quite reasonable that you're going to use an ACE inhibitor to control the hypertension in this particular patient, and they may have secondary benefits on exercise capacity in these particular patients. The next group of drugs are the angiotensin II receptor blockers. These ones can be used as an alternative to the ACE inhibitors. They haven't been shown to be superior to the ACE inhibitors, but they are less likely to cause those detrimental side effects like the angioedema. They are less likely to cause a cough. So generally, they can be used in chronic heart failure with reduced ejection fraction, so they're equally effective as the ACE inhibitors. Drugs like valsartan, 160 milligrams twice a day, candesartan, 32 milligrams once a day, losartan, 50 milligrams to 100 milligrams once a day. We introduce them also at a lower dose. We adjust them upwards slowly. We monitor the way we are monitoring with ACE inhibitors. We monitor the renal function. We monitor the potassium levels just like that. These ones also do cause some reversible renal dysfunction, so the dose must be reduced or they can be stopped temporarily if the patient has an acute dehydrating illness. So remember that you can add an ARB to a regimen that has an ACE inhibitor, beta blocker, and aldosterone, but you do not want to do this because it's not going to have much more benefit. You're just going to be increasing the risk of this patient developing hyperkalemia. Moreover, if the patient is taking an ACE inhibitor or an ARB and they're still symptomatic, then we can consider starting them on an angiotensin receptor blocker, or we can actually consider switching them to an angiotensin receptor blocker plus neprilysin. So in some randomized controlled trials where they used candesartan, there actually was a reduced number of hospitalizations in patients with heart failure with preserved ejection fractions for those that have recurrent heart failure, and hospitalization was a secondary endpoint anyways. So in another trial, they used another drug known as irbesartan, which was not associated with any significant improvement on the outcome. So in terms of the ARBs, they can be used in patients with heart failure with preserved ejection fraction only if you're using them in the background of treating this patient for hypertension, for example, diabetic kidney disease, or even microalbuminuria. But remember, ARBs, just like with the ACE inhibitors, contraindicated in pregnancy. Then these are the newer group of drugs which are known as the angiotensin receptor and neprilysin inhibitors. Remember that these are a newer group of drugs, and they're going to be including a drug class that's known as the neprilysin inhibitors, that's sacubitril. So remember that this neprilysin is just an enzyme that is involved in the breakdown of the vasoactive substances like the brain natriuretic peptide and other peptides. It's not going to be breaking down a specific type of natriuretic peptide that is known as the nitrogen terminus brain natriuretic peptide, or pro-BNP. So it means we can still use the NT-proBNP as a diagnostic tool in patients of heart failure to show that there is some strain on the heart that is being put. So when they inhibit the breakdown of the BNP, it means that these vasoactive substances remain in the blood and they can lower the blood pressure, they can decrease the afterload, and they will enhance natriuresis, the loss of sodium in the urine. So that's why these can actually be good to be added to regimens of patients. So in a random controlled trial that compared the sacubitril valsartan to enalapril, especially in patients that were between class 2 to class 4 heart failure, what we noticed is that the sacubitril and valsartan actually reduced the primary endpoints of combined cardiovascular mortality or hospitalization. Less patients were hospitalized, while the sacubitril and valsartan also reduced any other cause of mortality in this patient. So they are actually quite superior compared to just using ACE inhibitor on their own, which is why we must transition our patients from the ACE inhibitor or an ARB to them taking these angiotensin receptor blockers with neprilysin. So even in the hospital setup, they will experience less pulmonary congestion and they may have fewer early readmissions. So generally, the sacubitril and valsartan should be considered in all patients with stable heart failure with reduced ejection fraction, especially those with class 2 and class 3 symptoms. And if they are on optimal guideline directed therapy on the other drugs, and you find out that they have elevated levels of the natriuretic peptide before starting treatment. So you generally have three combinations of the drugs. You have the one that comes with 24 milligrams sacubitril, 26 milligram valsartan, 49 milligrams and 51 milligrams, 97 and 103 in that particular combination. Regardless of whichever strength that you have, you're going to be taking them orally twice a day. So it depends on which one you're going to start with. For example, you may start with the medium strength dose, the twice a day, 49-51. And this one is, for example, for patients that have been on an ACE inhibitor. If they've been on an angiotensin receptor blocker, you start off with this. Compared to the ones that have been taking low dose of ACE inhibitors, for example, they have been taking less than 10 milligrams of enalapril per day, or they have never taken ACE inhibitors or ARBs at all in their life, or they have low or borderline low blood pressure, then you can start off at a lower dose, 24 to 26 milligram combination. Remember, if they were taking ACE inhibitors, you want to stop them and wait for 36 hours before starting the sacubitril and valsartan. But if they were taking an ARB, you don't need to wait for this washout period. You can just simply switch them. The complications associated with this is that there's risk of hypotension, risk of hyperkalemia, renal insufficiency, and angioedema. And remember, the risk was less when we combined sacubitril with valsartan, but with the other groups of drugs, there is significant risk, which is why you cannot give this drug together with ACE inhibitors. Huge risk of angioedema. So in heart failure patients with preserved ejection fraction, in a phase 2 trial, we showed that the use of the sacubitril and valsartan reduced the NT-proBNP levels at about 12 weeks and the left ventricular atrial volume at 36 weeks. Then there is another study that's known as the Paragon Heart Failure Study, where stable population of patients with heart failure with preserved ejection fraction actually showed significant reduction in death and even hospitalization. So there have been lower hospitalization rates, though we still need a bit more time to study this and have a conclusive information. We now move to the next group of drugs, which are the beta blockers. Remember, these ones are going to be used not in the acute phase. We avoid them in the acute phase. So if there's any acute presentation, avoid beta blockers. If your patient has evidence of pulmonary congestion, avoid beta blockers. They are contraindicated in asthmatic patients, those with second and third degree AV blocks, those that have previous significant intolerance to beta blockers. So generally, they can be used in patients with heart failure with reduced ejection fraction. We can add them to the ACE inhibitors, generally if they are stable. So specific drugs like carvedilol, metoprolol, succinate, which is a long-acting metoprolol, can actually improve the left ventricular ejection fraction. It can improve the survival and other cardiovascular outcomes, especially in patients with chronic heart failure with reduced ejection fraction and those that have severe symptoms. After the initial treatment, your heart rate, your myocardial oxygen demands are going to decrease, your stroke volume and filling pressures are going to remain unchanged. So you having a slower heart rate and the diastolic function improvement, the ventricular filling is going to return to a near normal or more normal pattern. So there's going to be an increase in the early diastole, which will appear less restrictive for the patient. So it does increase the exercise capacity. So it does improve myocardial function, measurable in some patients after about 6 to 12 hours, but may take longer. Your ejection fraction, your cardiac output may increase, your left ventricular filling pressures will reduce. Remember that in patients with heart failure with preserved ejection fraction, there has been no evidence that these beta blockers are beneficial, unless if your patient has, for example, something else. So from this large registry, there's suggestion that beta blockers use is associated with improved outcome in heart failure with preserved ejection fraction, despite the relative prevalence of them having a chronotropic competency. For example, they are unable to raise their heart rate in response to, for example, exercise, increase in exertional demand. So many authorities, most of the large authorities actually have postulated or rather suggested and recommended that the first-line therapy for conditions where the ventricular rate is controlled, you can use beta blockers to control the ventricular rate, for example, in atrial fibrillation. So generally our dose also, we should start off low, 1/4 of the target daily dose. Then the dose is gradually increased over 8 hours as the patient can tolerate. The acute negative inotropic effect of the beta blockade may sometimes initially cause the cardiac depression and fluid retention. So we avoid these in the acute phase. And in these cases, generally we're going to increase the amount of the diuretic that we're giving, then we slowly up titrate the beta blocker whenever necessary. So tolerance may actually improve over time, and efforts should be made actually to reach the target doses. Carvedilol 25 milligrams twice a day, 50 milligrams for those that are above 85 kg, bisoprolol 10 milligrams once a day, metoprolol 50 to 75 milligrams twice a day. That's the tartrate. And then if it's the succinate extended release, 200 milligrams once a day. Remember that carvedilol, which is a third-generation non-selective beta blocker, is going to be a vasodilator because it blocks alpha receptors. It also has some antioxidant effects, and it's going to be the most widely studied beta blocker. And though the disadvantage of this is that it's quite expensive, even in our setup here. Some beta blockers, like those mentioned on the screen, they are not going to appear to be beneficial and may actually cause harm. But like I told you, in acute decompensation, avoid beta blockers until your patient is stable and there's no little evidence of them having fluid retention. For your patients with heart failure with reduced ejection fraction with acute decompensation and they're already taking beta blockers, in some cases you may not need to stop it. You may not need to decrease the amount unless if necessary. But from my experience, most of the time we do stop the beta blocker. So often your beta blocker sometimes can be continued in patients with acute heart failure exacerbation. If they're on a diuretic therapy, then you want to tweak the dose of the diuretic. Then the other group of drugs are the sodium glucose cotransporter 2 inhibitors. Remember, these ones are largely used in treatment of diabetes because they'll block the reabsorption of glucose. So they're going to be causing this glycosuria. They're going to be lowering the plasma levels of glucose. So they do have some effects on the vasculature. They do have some effects on the myocardium. So they're going to be used to prevent the heart failure from coming on, especially in type 2 diabetics. But now from research, it has been shown that this benefit is not only with diabetic patients, but even with non-diabetic patients, especially with 2 important drugs, dapagliflozin and empagliflozin. So one of the members, dapagliflozin, improves the symptoms, it improves the quality of life, it decreases the hospitalization and mortality rates of patients with heart failure with reduced ejection fraction whenever it's added, especially if they have elevated levels of natriuretic peptides. So like I said, the effect is good for both those with and without diabetes. So generally in a recent clinical trial, the empagliflozin was actually added, and it actually did show a reduction in hospitalization and even in death in heart failure with preserved ejection fraction, whether the patient had or they did not have diabetes. So it's good to add these drugs to your regimen. Dapagliflozin and empagliflozin may be given 10 milligrams orally once a day. Then there's often a 10 to about 15% reduction in the estimated GFR, which will not progress, and the glucosuria, and a small reduction in the body weight may be seen. But there is a risk of them having fungal infections, especially in the genitals. There is a frequent risk of them being hypoglycemic and them actually tipping them into diabetic ketoacidosis. But generally, the drug is not indicated in patients with type 1 diabetes, those with low blood pressure, those with a low estimated GFR less than 30, those with rapidly worsening renal function. You want to avoid it. The other groups of drugs like canagliflozin have not been studied extensively in heart failure, but secondary analysis actually can suggest that they may be beneficial for those patients that are diabetic. Then the last group of drugs that we'll talk about are the sinus node inhibitors. So generally, remember that in the sinus node, located in the posterior right atrium, there is a special channel which is allowing sodium and potassium current to flow through. And you call this as the funny channel, or this F channel. So this happens on the SN node and is only found in the SN node. It's not found anywhere else on the heart. So it means that if we potentially give them a drug that inhibits this inward movement of this sodium, this funny current, then actually we can prolong the time it takes actually to reach that critical spontaneous depolarization of those pacemaker cells of the SN node. So in essence, we can control the heart rate. So a drug like ivabradine, which is a funny channel blocker, can actually act to block the SA node and slow the heart rate. It won't have any effect on the contractility because the other cells are not going to be having this channel on it. So it's just pretty much in high concentration on the SA node. So it's going to be useful in treatment for those that have high heart rates. And it's not useful for treatment in patients who are not in sinus rhythm, by the way, because they are only found at the SA node. So here's a chart showing you the different groups of drugs: the ibravidine, beta blockers, ACE inhibitors, sacubitril and valsartan, diuretics, the SGO2 inhibitors, the gliflozins, the spironolactone, eplerenone, and the ARBs. You can actually take your time, pause this right now, get a screenshot. If you can't see it clearly, I think you can drop a comment. I'll post a link as to where you can actually find this particular image. So how do we now choose which drugs we're going to be using to which patients? Remember, we're going to be classifying our heart failure based on heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, heart failure with mildly reduced ejection fraction. We counsel our patients on the importance of them renewing their prescription, the importance of sticking to the therapy, how to recognize if they have side effects, when to contact the physician. So for those patients that have heart failure with reduced ejection fraction, the standard of care are these 4 things. They must be on a renin-angiotensin-aldosterone inhibitor. Typically now we want them to be on an angiotensin receptor inhibitor and neprilysin. Although patients can be on ACE inhibitors or ARBs, they could also be switched to the angiotensin receptor antagonist as well as the neprilysin if they tolerate. Number 2, they must be on an aldosterone antagonist. Number 3, you do consider beta blockers and as well as the sodium glucose cotransporter 2 inhibitors. So generally the therapy is typically titrated. I've given you the doses before, and the patients are given a drug from each class. So patients may be taking one of the classes of drugs prior to them actually having heart failure. So generally the order of therapy initiation and the rate of titration is highly patient specific. So it's not something that is going to be individualized for all patients. They may already be on these drugs. And remember, addition of these sodium glucose 2 cotransporter actually has been shown to reduce morbidity and mortality, especially when they're added in those patients that have elevated natriuretic peptide levels. Other therapies can be used, such as sinus node inhibitors for lowering the heart rate, especially if those patients cannot tolerate the beta blockers. Then in cases of those that have heart failure with preserved ejection fraction, these ones, there are fewer drugs that have been studied. ACE inhibitors, ARBs, and angiotensin receptor blockers can be used to treat the heart failure with preserved ejection fraction, especially if they have other comorbidities like hypertension and renal dysfunction. Generally, survival benefits have not been demonstrated in most of our clinical trials, so this is not going to be considered a standard of care as compared to those with reduced ejection fraction. The ACE inhibitor, the angiotensin receptor blockers and neprilysin have been shown to reduce hospitalization, but they do not improve outcome in this group of patients. And in one of the clinical trials, empagliflozin was shown to actually reduce the mortality and hospitalization in patients with preserved ejection fraction. Beta blockers only are going to be used, for example, if you want to control the rate in atrial fibrillation or following angina or following a myocardial infarction, generally contraindicated. For those that have severe heart failure with preserved ejection fraction, lowering the heart rate with a beta blocker will actually exacerbate the symptoms. So generally, remember, they do have a fixed stroke volume due to the severe diastolic dysfunction. So in these patients, the cardiac output is going to be dependent on the rate. So if you lower the rate, you're going to lower the cardiac output at rest and at exertion, so potentially worsen their symptoms. So in patients with infiltrative, restrictive, and hypertrophic cardiomyopathies, digoxin is not effective and may actually cause harm. And then in addition, the vasodilator therapy may also be poorly tolerated and has not shown so much benefit in these particular patients. While in those with mildly reduced ejection fraction, generally there is specific benefit for the angiotensin receptor antagonists and neprilysin, though this possibility requires to be confirmed by further clinical trials. They do also benefit from the sodium glucose cotransporter inhibitors like empagliflozin to be added to their standard of care. Generally, the drugs that you do not want to use in heart failure, NSAIDs, essentially are okay. Low dose aspirin is okay, but you want to avoid giving them for a very long time. Steroids, you want to avoid them. Most calcium channel blockers, like the ones that are rate limiting, verapamil, diltiazem, the pioglitazone, tricyclic antidepressants, beta agonists, these ones should be avoided in heart failure. The non-pharmacological management surgery could either be coronary bypass grafting, it could be percutaneous coronary interventions, which could be done in myocardial infarction, it could be valve replacements, it could be biventricular pacemaker heart transplants, it could be left ventricular assist devices. These are the various non-pharmacological surgical interventions that your patients could actually undergo. Now, last but not least, or second last thing, if your patient has intractable heart failure, what are you going to do? You want to reassess the cause of the heart failure. Maybe it's something else. Are the patients taking their drugs? Are the drugs optimal? Are they at maximum dose? If they're on furosemide, switch them to bumetanide. This might sometimes help. You want to have a strict bed rest for this patient, sodium and fluid restriction to less than 1.5 liters over 24 hours. Give them some metronidazole combined with IV furosemide. Opiates and IV nitrates can relieve the symptoms. Daily weigh them. Check their UNEs to be looking out for hypokalemia. Give them some DVT prophylaxis, heparin, low molecular weight heparin, and compression stockings. And once they're in the extremes, then you can try inotropes. But remember, once you start them on inotropic support, very difficult to take them off. And generally, it is associated with increased mortality. You may consider cardiac resynchronization and left ventricular assist devices or a transplant in this particular patients. I really hope you enjoyed this video on heart failure treatment and heart failure management. I know it was a very long video. That's why I wanted to do it separately. If you did, consider subscribing to the channel. Hit the bell notification icon to receive notifications of such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.